All right, let's continue. Before I ended for the break, we were here. Let's discuss diabetes and metabolic syndrome. Metabolic syndrome is not different from the metabolic syndrome that they will mention in chapter 38. This is a risk factor for cardiovascular disease, and at the same time, they are also a high risk factor for diabetes. These are the characteristics of somebody with metabolic syndrome. They resemble pretty much the same risk factors as listed down here in table 64-5. These are the features. Everybody with metabolic syndrome are obese, particularly a waist circumference of 40 inches in male and then 35 inches for females. And they have hyperglycemia, hypertension, hyperlipidemia. And like I said, these are both risk factors for heart disease as well as diabetes. Like I always mention in class, please read all patient-centered care boxes. These are here for a reason, so they may be questions on the exam, not only for mine, but also for the NCLEX. So who are going to be tested for diabetes? So if you have these features here, if you have one or more, so it clearly says here with one or more of these risk factors, okay, if you have, let's say, BMI greater than 25, then plus you have one or more of these here, then you have to be tested, or you are recommended for being tested for diabetes. Of course, with any disorder, we'd like to prevent it rather than cure. Diabetes is a chronic disorder, chronic progressive disorder. So it's easier to not get there. The ideal is to not become diabetic, because once you are diabetic, doesn't mean it's hard to control, but we'd rather not get there in the first place. So it is all about eating healthy, controlling your risk factors. Since these are the risk factors here, try to eliminate them. For instance, of course, this one, the genetics, we cannot eliminate that. Okay, but if you have that in the family, then you have to take measures in order to modify the other risk factors. Control hypertension, your blood pressure, control your cholesterol levels, increase activity, okay, and then lose weight. These are the recommended exercise weekly, about 150 minutes. So that's about 30 minutes a day, 5 days a week. All right. Diagnosis of diabetes. We will discuss testing. Okay. These are the results that mean you could be diabetic. Okay. Of course, you should be familiar with the normal ranges for these three tests, and these are the significance of your results. Okay. I'd rather discuss table 64-6. You can read this chart for yourself, chart 64-1. Okay, now table 64-6. A1C is listed here first. The reason is this is the most reliable test because this gives you 3 months worth of data. You can read about glycosylated hemoglobin or hemoglobin A1C test here. So as described, this is the standardized test that measures how glucose permanently attaches to the hemoglobin molecule. Now, the hemoglobin, glucose normally attaches to hemoglobin, meaning, and as they do that, here there's a process called glycosylation, meaning they stain the hemoglobin, meaning when they attach to the hemoglobin molecule, the sugar leaves a sugar stain called glycosylation. So therefore, as described here, the higher the blood glucose is over time, the more glycosylated hemoglobin becomes. Okay, so of course this is a more reliable test because based on the fact that red blood cells have what lifespan about 120 days. So therefore, and this is in percentage, meaning if let's say if your glycosylated hemoglobin or 6.5% or more of your hemoglobin are glycosylated, that gives you an idea. There's actually a table here, table 64-7. You don't have to memorize this is not testable, but this gives you an idea about how bad the implication is. So for instance, if your A1C is 6, that means your average, okay, so your mean, okay, your mean or average blood glucose is about 126. So the higher you go, up to 12 here, for instance, look at that. This is the mean glucose at any time of the day. That is significantly high. Okay, so that's why A1C is the most reliable, because this test can't be affected by factors that the patient does in a few days before or after the test, mostly before. For instance, if we do fasting blood glucose and your result is greater than or equal to 126, this is also what is this? Suspicious for, I should say, suspicious for diabetes, but this can be affected by several factors. Meaning, let's say, what if the patient before this test have been very good with their diet? Okay, so let's say within the past week they've been, or even the day before, they've been very good with their diet. No, they haven't been eating much, for instance. So that will affect the result of the fasting blood glucose. Same thing for the 2-hour postprandial. This test here, this test is done by usually the doctor will tell you to eat, and then 2 hours later after the meal they'll check your blood glucose. So if your sugar is still equal to or greater than 200, that means there is your pancreas has an impaired ability to lower the blood sugar, because 2 hours after, that sugar shouldn't be high anymore. It should be back to normal. Okay, because that's how normally the body works. Okay, so if your sugar remains 200 or more, then you could be diabetic. But again, my point is this can be affected by eating habits by the patient. So let's say after a meal, for instance, the patient didn't eat a good meal, okay, unless of course they went to a doctor's office and they were actually given the glucose preparation, then in that case, yes, it can't be cheated. Okay, and then random here, the last one, random glucose concentration, meaning we'll just take your blood glucose at any time randomly. So if the result is over 200, okay, greater than 200, then you could also be diabetic. But again, this is not not the most reliable, meaning the doctor may still order these, but in order to make a diagnosis it must be supported by the A1C. A1C remains the most reliable test. Okay, again, this is the standardized test for diabetes. It's done both to diagnose diabetes and also to monitor their compliance or response to treatment. Yeah, so because it cannot be affected by the patient's habits during the past week, because for them to cheat this, I mean, you have to be cheating for a whole 120 days. Okay, because you can't cheat data over 120 days, which is again the lifespan of your red blood cells. Okay, let's go to treatment now. The goals are, of course, these. Okay, please read that on your own. Let's start with oral hypoglycemics first. Okay, drug therapy. chart 64-2. Now, this is a long chart, okay, but the drugs have similar names. For instance, sulfonylureas, for instance, these are their names: glipizide, glyburide, okay, glimepiride. So they sound the same. Their action is this: they lower blood glucose by triggering the release of insulin from the beta cells. So by the action itself, you can tell this is only for type 2 diabetes. Of course, we already cleared that up during the first hour, wherein because the type 1 diabetes has absolutely no insulin, so there's no way this drug will work on a type 1 diabetic. Okay, so type 1 diabetes again is exclusively treated with insulin only, because if you give this, I mean their pancreas is incapable of making insulin, so therefore this is only for type 2 diabetes. Because it triggers your own body to release insulin, therefore of course it will make sense that its number one side effect is hypoglycemia. So it will be dangerous to pair these drugs here with insulin. I mean, I'm not saying doctors won't, they can, but there will be a warning that this will increase the likelihood of hypoglycemia, because again it triggers the release of insulin from the patient's own pancreas. Plus, if you give more insulin on top of this, then most likely your patient might go hypoglycemic. Please read the side effects on your own. Again, so insulin stimulators, so these are sulfonylureas, trigger the release of insulin, so therefore they act on the pancreas. There are only 4 possible targets of oral hypoglycemics. One is pancreas, meaning some drugs will trigger the release of insulin. Let's go over here. So oral hypoglycemics, have actions on 4 areas. One is the pancreas. Next is the skeletal muscles. Next is the liver. And lastly, the liver production, pancreas, skeletal muscles, liver production, and what is the 4th one? Oh, it'll come back to me. Okay, so this one, in the case of the pancreas, so this one, of course, some drugs will trigger insulin release. Some drugs will make the skeletal muscles more sensitive to insulin, increase sensitivity. And then finally, this one, liver, will decrease liver production of glucose, because we know that glycogen is stored in the liver. Oh, I remember now. Okay, the GI tract. 4th action, possible action, is to decrease absorption of glucose. Or delay absorption. Okay. So 4 possible actions. Some drugs may have more than one action, but they all target these 4 areas. Any of these 4 areas. So a drug can either trigger insulin release in the pancreas, or make the muscles more sensitive to insulin, Next is they will decrease liver production of glucose, thereby, as you can see, all these things here lead to hypoglycemia. Okay, GI tract, in this case, it will either decrease or delay absorption of glucose in the GI tract, thereby lowering blood sugar. Okay, please do not assume that because these are all oral hypoglycemics that all of them will have hypoglycemia. They do not. For instance, let's say, look at this next group, for instance. Okay, so biguanides, there also only one drug, it is metformin. So this thing works by inhibiting liver glucose production, decreasing intestinal absorption of glucose, plus increasing insulin sensitivity. So this drug has three actions. Okay, so but as you can see, there is no hypoglycemia listed as a side effect for this drug. I mean, it's possible, but it's not known to cause hypoglycemia because it doesn't trigger insulin release. Okay. Again, I'm not saying it won't cause hypoglycemia, but I'm just saying it's not known to commonly produce hypoglycemia. Okay. And here are the warnings for this drug. Some of you probably already know this, that we should not be given this drug for 2 days after any test involving IV contrast dye, because that can increase the likelihood of kidney damage, meaning the drug itself is already nephrotoxic. So we do not want to continue this drug after the patient receives IV contrast agents or dyes, because those agents are also nephrotoxic. So that will be a double whammy for the patient. So again, if the patient is a known diabetic, known to be taking metformin, that drug must be held for 2 whole days after the testing. Okay, so that should give the kidneys enough time to recover from the contrast agent before you resume this drug. Here are insulin sensitizers. By the name itself, they decrease low liver production of glucose, plus also makes the cells more receptive or sensitive to insulin. The drugs here are thiazolidinediones, pioglitazone, rosiglitazone. If you remember these two drugs, they were mentioned in chapter 35 under heart failure. These two drugs, along with NSAIDs, were in a drug alert, telling you that these are contraindicated in patients with heart failure. Correct? If you remember, I'm sure you do. So that's why this is the reason here. So here, because these drugs can trigger or cause cardiovascular disease, these are your teachings for the patient. Okay, so here there's a black box warning for these drugs, not to be given with anyone with heart failure. Here are other side effects. So there's macular edema as well, which makes sense. This one causes, I guess, increased preload. So if it causes that effect to the heart, it will also do the same in your eyes. Also triggers osteoporosis, I guess, because here increases the risk for bone fractures because it decreases bone density in women. Okay, and then next group, Acarbose. Okay, so Acarbose acts by inhibiting enzymes in the GI tract. So this, of course, decreases hyperglycemia by decreasing absorption of glucose in the GI tract. Okay, these are your side effects, and here is a teaching here. These drugs should only be taken with a meal. So if the patient skips a meal, then they have to skip the drug as well. You will see this drug again next semester when you talk about dumping syndrome, which is common after radical gastrectomy. because of its action. Okay, so it delays the digestion of glucose, so this will benefit patients with small stomachs or patients with no stomachs. We have incretin mimetics. We have a lot of drugs here. I'll only ask you about dulaglutide, which is Trulicity, and Victoza, liraglutide. Okay. Now, this is the action of the drug. They act on the liver. Okay. It reduces glucagon secretion, although it acts on the pancreas, but the action actually is on the liver still, because glucagon acts on the liver. It delays gastric emptying, thereby slowing the absorption of glucose in the GI tract. Now, these are injectables. Okay, this is a subcutaneous injection, but this is not insulin. Okay, it only works with insulin, but this drug is not insulin. Okay, let me just make that clear, because these are injectables. These two drugs are injections. They are subcutaneous injections. They do come in pens. Okay, we'll discuss pen use later. Here's the second drug that triggers hypoglycemia. Okay, so far we have two. We have sulfonylureas, hypoglycemia, and then we have incretin mimetics or GLP-1 agonists. We have hypoglycemia here as well. So patients need to be aware of those signs and symptoms. And then lastly, no, not the last yet. We still have a few. We have amylin. No, I skip one. Sorry, DPP4s. So this one has a couple actions. So decreases pancreatic glucagon secretion again. So therefore it will decrease liver production, and then also delays gastric emptying. So this is now the third drug that known to cause hypoglycemia. And they will just use sitagliptin, Januvia. Okay, and then I'll skip amylin analogs because they're not very commonly used. Farxiga also will okay, so I was right, this will be the last one. Okay, so we'll end at DPP4 inhibitors. Okay, so again, I'd like to emphasize that not all of them are commonly known to cause hypoglycemia. So far on this chart we have three. So we have sulfonylureas, we have GLP-1s, and DPP4s. Okay, and please read the paragraphs on how they work. I won't read that for you. Here's a warning again on metformin, which was already mentioned in the table. Or was it a chart? A chart, sorry, 64-2. Okay, so I may get some of the questions here. Okay. So here's one for Trulicity or dulaglutide. All right, let's go to insulin now. So this obviously is not only for type 1, but some type 2 patients may be put on insulin. Table 64-8. Now you have to learn onset, peak, and duration. The reason is this onset means this will help you decide when to give the insulin to the patient in relation to a meal. Peak will tell you, because this is the highest drug action, so this will give you an idea when to check your patient for hypoglycemia, which is the number one side effect of all insulins. And then finally the duration, meaning how long does the insulin work. Okay, which will determine when you can safely give another dose. Again, onset is needed for in relation to a meal, meaning when you give the insulin as to the patient's meal tray. Then peak again is when you check the patient for hypoglycemia, duration will be, of course, because that's the end of the effects of the drug, then you can safely give another dose. Okay, so we have rapid and short acting insulins. um, as usual, we will only use generic names, so please be familiar with the generics. Okay, so only on this side, sorry, the first column. Okay, so the first column here, Aspart, Lispro. All right. We do have inhalation insulin powder now. These are sprays. Okay, these are new. They are not very commonly used in the hospitals yet, but at home the patients may be already on these. Okay, they made the powders, the sprays, because it's convenient. There's no need to inject anything. Okay, so they can do this more conveniently. So rapid insulins have anywhere between a 15-minute or a usually 15 minutes. Okay, so for Aspart, Lispro, they are all 15-minute onset, meaning you should give them there for 15 minutes before a meal. And it peaks, there's a range here, so you can say just the middle. So if this says 1 to 3 hours, then you go with the median, which is about 1.5 hours. Don't worry, on exam I won't let you choose between 1 and 3. Okay, the choices will be either within that or way outside, either way below or way after that time. And this is the duration. So which makes a rapid and short acting insulin as the perfect options for random sugar spikes, for instance. Okay, plus they don't last long, so making them very effective with less likelihood of side effects because they don't last very long. Aspart is used frequently for pre-meal insulins. Look, it's about 3 to 5 hours, so makes them the perfect choice for between meals. So because we eat about every 4 hours pretty much during the day, or every 4 to 5 hours, so making them very useful. Short acting, there's only one regular insulin. This is the only insulin given IV. It has a 30-minute onset. All of them have 30 minutes. They peak around 2 hours. Okay, and then they last about 5-6 hours. Okay, 5 to 7 hours. INH is intermediate. Look at the onset. The onset is 1.5, so which makes these types of insulin not ideal for pre-meal because it's very unpredictable. The only thing you have to remember on how these are used is they have to be given about the same time every day. So doesn't have to be within a meal, because look at this, you'll have to if you use this, then look at that, you'll have to give it to yourself 1.5 hours before a meal. But again, the duration, the peak is so wide, so making them impractical to be used for mealtime insulins. Okay, the use of intermediates are to give you a more steady this insulin coverage because it lasts longer. Look, it has about 16 to 24 hours, okay, of duration. So usually how these are used is either the doctor tells them to take it at 9 a.m. and 9 p.m. or 10 a.m. 10 p.m. Okay. Long-acting insulins. Now only Lantus or insulin glargine is the true insulin with no peak. Okay. The reason I mentioned that is some nurses think that all of these have no peak. That is not true. Only Lantus or glargine has no peak. Okay, so please take note that this one's another glargine, but this one is more concentrated. This one is U300. Lantus is the traditional 100 unit per milliliter concentration. Toujeo is different. Okay. Again, only Glargine has no peak. The others, including Detemir, which is Levemir, it does peak in 6 to 8 hours. Same thing for the U300, the Toujeo type of Glargine. It also peaks now, 12 hours. Tresiba is fairly new, and this was in the last 3 to 5 years in the market. Look at this duration. They have 42-hour duration. Okay. I won't test you on the regimens because it takes experience with learning insulin regimens, and I don't think it's fair to test you on this without clinical experience. Okay, so we can skip the regimens. Okay, let's discuss now where to give the insulins. Okay, so you learned in fundamentals of nursing about when to where the injection sites are. Please take note of what I highlighted here, that rotation within one anatomic site is preferred to just randomly giving it. What I'm trying to say is, so let's say the patient, you're the nurse giving this to this patient. So when you give it throughout the day, so let's say this patient gets insulin 4 times a day, before meals and at bedtime. So try to stick with, let's say if you decide to give it on the arm today, so give it all in the arm. Okay, so you stay from here, breakfast here, lunch, dinner, bedtime, and then proceed with breakfast, lunch, okay, and then go on to the other side. Okay, so don't go breakfast here, lunch here, dinner here, right? Because this is the consequence, because there will be variability in absorption if you go from one anatomical site to another. There are 2 problems that can arise from insulin. They call them Somogyi phenomenon and Dawn phenomenon. Okay, the illustration here, figure 64-4. So both conditions, whether it's Dawn in red or purple, Somogyi axis, okay, they have 2 different causes, but both will result in morning hyperglycemia. If you look at here in the graph, both these patients at around 6 or 7 a.m. have a very high blood sugar, about 220 or 230 in the morning. Okay, both conditions again result in morning hyperglycemia. This is actually more common than you think. If you have the ability, let's say you guys have access to Epic or whichever, if you still go to a facility using Quadramed, doesn't matter. If you graph the POC glucose, the point of care glucose results, if you graph them, you'll see Dawn and Somogyi phenomenons in one or more of those patients. Okay, if you're observant, they typically have either Dawn or Somogyi phenomenon. Okay. Now, as stated here, Dawn phenomenon is a result of the nighttime release of adrenal hormone, meaning there is obviously not enough insulin to hold them until morning. Okay, so that's why the suggestion, the recommendation here is to give the evening dose of intermediate insulin, which is NPH, at 10 p.m. instead of during the evening meal. So meaning instead of giving the intermediate insulin, the NH, around here, earlier here, they suggest giving it later around here, okay, around bedtime or 10 p.m. That way because it peaks around 6 to 8 hours. It doesn't peak until later here in the middle of the night. Okay, so after midnight. So that way, instead of the sugar going up like this in the morning, the sugar will more go steady around here because you still have some insulin effects left. Okay, so this is the one of the um, uses of NPH to control dawn phenomenon. Whereas Somoji phenomenon, this is again the patient goes into hyperglycemia, morning hyperglycemia. However, the cause is different. So here, instead of having not enough insulin, which is the case in the dawn phenomenon, in Somoji, there is not enough food. Okay, so that's why the management recommendation here is to give this patient a bedtime snack. So therefore, if you have a snack around here, the bedtime snack, of course, shouldn't be a simple carbohydrate. Should be protein, some protein with carbohydrate, or a complex carbohydrate at least, so that instead of your sugar going low around 4 a.m. or 5 a.m., it will remain steady. Thereby, you won't have a rebound or a compensatory mechanism, because of course when your sugar goes low, your body's counter-regulatory hormones kick in. They will release glucagon, which will break down glycogen from the liver, causing the sugar to rise. So if you don't go hypo in the first place, meaning if we give a bedtime snack here, again a complex carb with protein, so the sugar will remain steady here instead of going down, thereby preventing a counter-regulatory response. I'm not testing the insulin pump. This is not very common. These are used by the younger generation, usually athletes or students like you, students your age, people with active lifestyles, because they don't have the time to frequently check their sugar, so they can manage their diabetes better with the insulin pump option. So this thing here is a sensor which communicates wirelessly to the pump. Okay, the technology has been around with the insulin pumps, but now the technology of wirelessly sensing the checking sugar without finger sticks is now being adopted by other companies now, namely Freestyle, Libre, and we also have Dexcom. Okay, but the technology actually has been around. They just didn't think about commercializing it until lately. Okay, so again, this thing is, both of these actually are put in only once a week. So this thing is changed. You don't see it, but there's an adhesive, there's a transparent adhesive here around this thing. So this is there's a needle in there, a small needle attached to the patient's body, and then of course the adhesive keeps it in place. So this thing wirelessly, this monitors the sugar, blood sugar of the patient, and then wirelessly connects it, transmit the results to the pump. Okay, so this small computer here, and then the pump will be programmed to give the patient a steady insulin infusion, okay, slowly. So there's a tiny needle also here, which will constantly deliver tiny amounts of insulin to keep the patient's glucose normal. During a meal though, because the patient now will be getting a bolus of sugar when they eat, the patient therefore will also program the pump to give them a bolus depending on the amount of sugar they're eating. So the patient will be trained by a dietitian and endocrinologist on how to calculate the equivalent of a meal, and that's what they enter on the pump to calculate their bolus insulin. Okay, storage of insulin. There are rules here. If the patient has not, if the insulin is not in use, they should be refrigerated. Okay, so we teach the patient to refrigerate insulin that is not in use, meaning the vial hasn't been opened yet. However, if you're already used the insulin, meaning the vial has already been opened, they should be kept at room temperature up to 28 days. The exception is Glargine or Lantus, which still has to be stored in a refrigerator even when in use. But all other insulin, again, insulin in use must be at room temperature, except Lantus, which remains in a refrigerator whether or not it is used. Please review chart 64-3. This was already previously learned on how to draw insulin and how to administer insulin in NUR 101. The pen device. Let me show you what a pen looks like. Okay, so these are insulin pens. As you can see, the pen is actually contains a vial inside. Okay, so but unlike a vial, wherein here's a picture of a regular vial, right? So the only opening is the rubber stopper on top. The bottom of the vial obviously is either glass or plastic. In the insulin pen, the vial here, the bottom of the vial isn't solid like this. It isn't plastic or glass. The bottom is rather a rubber stopper. Okay, so it's therefore here it is. Here, if you can see here, the rubber stopper, and this is now obviously a quarter empty, so you can see the rubber stopper right here in the middle. Okay, of course, if this is full, this would be, of course, all the way over there, so that's why you can't see it in these other pictures. But here is the visible rubber stopper. So whatever you do, please do not use the insulin pen as a vial. Okay, because some nurses are lazy, and if they can't find the insulin vial, they'll grab somebody's pen, which is nasty, and then they'll draw insulin from the pen. Now you shouldn't do that, because like I said, this thing is not made to wherein you can draw insulin from it, because if you do, this is not pressurized. It is not like a vial wherein it's okay to do that, because you can displace air. So since you can't displace air in this thing, because this has a rubber stopper and not a solid base, not a solid bottom, you will create a vacuum inside. So there will be an air bubble created inside if you draw insulin from it. As a result, the next time the patient uses this as a pen, the patient might not get any insulin, but instead they will get air. Okay, which can be dangerous, because the patient used the pen thinking that they got insulin, but then instead they will end up getting air bubbles instead. And then that's when we get problems. Now the patient will have hyperglycemia as a result. These are the teachings that the patient must be aware of. This is part of client education. They should be taught the following. Because insulin is going to cause hypoglycemia, so of course naturally the patient must be aware of both, not just hyper, but also signs and symptoms of hypoglycemia. We'll get to that list later. There will be a table or a chart. Hypoglycemic unawareness. This can occur with patients with long-standing diabetes, especially those who are taking beta blockers. What happens is since hypoglycemia is life-threatening, it is an emergency, it will trigger adrenergic symptoms. Adrenergic symptoms are those symptoms of sympathetic nervous system, fight or flight. If you remember in chapter 11, the response is, of course, increased heart rate and vasoconstriction. So the patient will have palpitations. The patients will have sweating because of vasoconstriction. There is no blood flow going to the skin, so therefore sweat glands will be activated. So the patient will have palpitations. They'll feel nervous, and then of course they will have the cool and clammy sweating. Okay, cool clammy skin. Now, if you take beta blockers, because those drugs inhibit the adrenergic symptoms, meaning instead of having palpitations or tachycardia and vasoconstriction, you'll have the opposite. So therefore, if a patient is taking beta blockers and have been a diabetic for a long time, they may develop hypoglycemic unawareness, which can be dangerous because now, as a result, instead of the patient being aware that their sugar is low, they won't be. Okay, which is again, hypoglycemia is a life-threatening emergency. We will teach the patient periods of illness, what to do during periods of illness. Contrary to most lay people, they will think that their insulin needs will decrease during periods of illness because they're not eating well. Our appetite isn't as good, and we have poor intake when we are sick. Remember that when you're sick, when you're under stress, your cortisol levels do rise. And since those are glucocorticoids, they will increase blood sugar production in the body. Please just make the patient aware that food is not the only source of blood glucose. Our body is capable of producing glucose from the liver, from your fats, from your proteins. Okay, so the patient needs to know about that. We also discuss how to manage blood glucose before and after exercise, gastroparesis as a complication of as a macrovascular complication of diabetes, and adjustment of drugs, and what to do when the patient is receiving other therapies like exogenous steroids, for instance, for an infection, for instance, or no, not really an infection, but rather as an exacerbation of some autoimmune disorder. For instance, let's say you're taking steroids for asthma, or from exacerbation of COPD. Okay, or if you have to take steroids because you have received solid organ transplant, for instance, or during pregnancy. Okay, you have to make adjustments as a diabetic. So if you read these paragraphs here, they all emphasize about the importance of SMBG, or this is self-monitoring of blood glucose. It's really important that the patient manages this themselves. Of course, we have exceptions for those who are physically or cognitively unable to do so, but as much as possible, the patient themselves must be monitoring the blood glucose, because you get to know your body that way, and they can make adjustments to their food intake, their insulin dosages, etc. I already mentioned alternate site testing earlier. The options now, we have Dexcom, we have Freestyle Libre. Okay, these most of these don't require frequent blood sugar sticks anymore, meaning they can put in a patch which monitors their blood glucose wirelessly. Some, they don't even require the machine anymore, they can do it with their phone. Okay, so making SMBG more user friendly also increases compliance, because the patients, of course, nobody likes to stick their fingers 4 times or more a day, right? So these alternate sites testing provides them that flexibility. Nutrition. All right, I won't be a hypocrite, and neither will the NCLEX. NCLEX recognizes that new graduate nurses are not proficient in providing dietary advice, nor are we competent okay, or even comfortable. So this should only be done either by a registered dietitian, a diabetic nurse educator, of which none of us are diabetic educators, so they will not ask you questions about what to teach the patient about nutrition. Okay. This one is, of course, this can be testable. Okay, how alcohol affects glucose levels. So please read the effects and how much alcohol should be taken only, the limits that the diabetics will take. So here, for instance, if you're taking sulfonylureas, right, here's a warning. Okay, there's a risk for delayed hypoglycemia. Okay. I guess the idea behind it is because alcohol is also food. It's mostly carbohydrate, so it should be always taken with moderation. Okay, let's go to exercise. Yeah, okay, here, exercise. Okay, I encourage you to read the whole paragraph. But let me point out some things here. Please read this. So it says low insulin levels trigger the release of glucagon and epinephrine. Of course, those are our responses to low blood sugar. So in the same way, when your insulin levels are low, it will trigger the release of glucagon and epinephrine. So therefore, exercise has the potential of raising blood glucose. However, as look at in the second statement, it says here, in the absence of insulin, free fatty acids become the source of energy. Exercise in a patient with uncontrolled diabetes results in further hypoglycemia and formation of ketone bodies. Now remember these two statements when we go to the guidelines. Okay, so here are the guidelines for insulin during exercise. Okay, read the rest. Let me point out a few things here. One is warn the patient not to exercise within an hour of insulin injection or near the peak insulin action. Obviously, because exercise causes you to burn sugar, okay, and then also makes your muscles more sensitive to insulin. So therefore, since insulin peaks at this time, so therefore it's not advisable to exercise at that point, because that will further trigger or result in hypoglycemia. And here are two basic guidelines. Do not exercise unless your sugar is between 80 and 250 milligrams per deciliter. Again, do not exercise unless your blood glucose is between 80 and should only be at least 80 and 250. Reason is, of course, if it's less than 80, then you're already hypoglycemic, so exercise will cause further hypoglycemia. And in the case of 250, so let's say the sugar is really 251 or higher, and then you exercise. Remember that the patient, the blood glucose of the patient didn't get to 250 easily. Okay, there were a series of events. If you remember in our drawing here, in our explanation here, okay, look at this part here, the first part. We said that the hyperglycemia, this condition right here, did not occur easily. This several events happen before you reach severe hyperglycemia, meaning before you reach 250, these events here occurred, meaning the patient did not have insulin, and therefore the patient's blood glucose, not only from the food intake, already broke down glycogen, fats, and proteins. That's how they got to the 250 level. Okay, so at this point, the patient's body already started breaking down fats, okay, when you got to the 250 level. So therefore, if you were already in this condition and you still did not control it and instead did exercise, the opposite will now happen, because you were already in this condition here. Instead of the sugar going down, it will actually keep going up. Okay, so only in this condition. So again, if your patient's sugar is already at 251 or higher, they should not be advised to exercise. They should drop that sugar between 80 and 250 first before they exercise, because otherwise this condition here, remember I said that this will now be a vicious cycle. Okay, so the cycle must be interrupted first. This sugar must be back down to 250 or less before they can safely exercise. All right, this part here is about controlling glucose in hospitalized patients. Okay, let's talk about patients who are NPO, because we have a few of those. We put the patients on NPO, even diabetics, for procedures, for testing, surgeries. Okay, if you read the highlighted portion, so I'll read it for you. There's confusion about whether to give or to hold insulin from a patient who is NPO. Okay, administration of rapid or short-acting insulin will cause hypoglycemia if the patient is not eating. So yeah, that makes sense. However, basal insulin should still be administered when the patient is NPO, because it controls baseline glucose levels. Insulin mixtures, so this would be NPH, is not administered because they contain some short-acting or rapid-acting insulin and will cause therefore hypoglycemia. Okay, let me explain this. Some patients will be given basal insulin. Not all though. Okay. We have basal insulin, and then we have what we call the sliding scale insulin. Basal insulin, again, this is not given to all diabetics. Only certain types of diabetics, usually the ones that have severe insulin resistance, are given basal insulin, meaning regardless of their blood sugar, regardless of glucose, basal insulin is given. Okay, we don't even need to check. Usually, well, we still check sugar in the hospital, but patients getting basal insulin is meaning they have really bad insulin resistance, that they are given a a certain amount of rapid acting or short acting insulin, okay, regardless of their blood glucose. Then if their sugar is higher than their base, for instance, the doctor may say, give them orders of, let's say, 150 to, if the blood sugar is 150 to 200, give 2 units of insulin. Okay, and then so on, 201 to 250, give, let's say, 4 units. Okay, blah blah. So on top of the basal insulin, so let's say the basal insulin is 5 units. If the patient's sugar is, let's say, 150, they won't get the sliding scale because this one says it has to be given once they hit 150. However, for 150, they will still get their basal insulin of 5 units. And then when they get to either 151 to 200, then on top of the 5, they will be given the extra 2 units. Okay, so that's the difference between sliding scale and the basal insulin. Okay, so this is what they mean by here. Only basal insulin if the patient has an ordered basal insulin, but otherwise if the patient is NPO and they have no basal insulin ever prescribed, then they must the sliding scale insulin must not be given. Okay, so clear. Rapid acting or short acting insulin must not be given. Are there exceptions? Of course there are. If you remember in chapter 14 under skip, okay, under surgical care improvement project, one of the core measures there was to control for cardiovascular patients, especially those getting let's say going to surgery or having open heart surgery. Okay, their blood glucose must be controlled by 6 a.m. Those are exceptions. Okay, if they have really high stress levels which will shoot their sugar to 200 or 300, then you will have to call the physician and they'll give you a order to drop the insulin as close to normal as possible. Okay, there are always exceptions. This part here we will not discuss because this is involving treating diabetes with surgery. This is referring to, of course, pancreatic transplantation, meaning the patient has diabetes, so therefore, especially type 1 or even type 2. So they will get a new pancreas. Well, not really new, but a recycled pancreas from a non-diabetic. But we don't see. I personally have never seen a patient who was treated diabetes that way. So we can disregard this because we've seen even rich people who have millions and billions of dollars. We never hear them getting pancreatic transplants. Okay, so we'll skip this part here. Alright, I guess it's time for another break. I'll see you on the third and last video.